I'm going to ask Stan, our chaplain to the Australian Christian Nation Association, to open our forum in prayer. Thank you, Stan.
Blessed Lord God, how wonderful a thing it is that you give wisdom to people, to give them things that they can pass on to others. We thank you for people who invent things and teach things. And we pray, O Lord, your blessing upon us as we listen today. Open our hearts as well as our ears, that we might listen by our spirits to your Holy Spirit. Lord, we thank you for all the wonderful things that are invented and discovered. We thank you for medicine, and we thank you, O Lord, for all the great inventions. And Lord, we sometimes forget that people sometimes can take hold of these wonderful things that you're given to us and spoil it. And so there are many people whose lives have been spoilt by the wrong use of the gifts that you give to us. So be with your servant Stuart as he speaks to us. Help this work of the Australian Christian nation, and grant indeed that many more people will come to understand that we want to see your name upheld. So we commit ourselves into your hands and ask your blessing for Jesus' sake. Amen.
Now it's my distinct pleasure to introduce our guest speaker, Professor Dr. Stuart Reece, who I've known for many, many years, probably since he was a boy, for a long time. And I've appreciated all that he's done in the area related to drug use. Stuart's been very active for many, many years and has had a large practice in addictive medicine since 1996. So he has practical experience about this issue. He's had over 85 papers, that's official research papers, published in peer-reviewed medical literature, in most of which he is the sole or principal author. In 2018, he was appointed as adjunct clinical professor of medicine at the Edith Cowan University, and has held an associate chair of medicine at the University of Western Australia since 2010. So he's regarded worldwide, not just in our country, as one of the foremost authorities and as one of the most sought after experts on the patterns of cannabis-related illnesses, particularly as relate to childhood and utera exposure in pregnancy. He's a principal author of the major research into the acceleration of the aging process by cannabis, and has published careful solo reviews of cannabis toxicology. So he's done a tremendous amount of research, and I know that because he is in touch with me regularly, what he's doing, what he's writing. And our next Family World News will be on this whole issue of medical cannabis and legalised pot, and he'll be writing a leading article for the Family World News for August issue. So you're getting an advanced introduction today on the work that he's been doing, which is outstanding, and probably I'd say he's a pioneer in the harmfulness and the dangers of cannabis and so on, which we know there are other people saying it's now harmless and a very safe recreational drug. And the Greens believe that, and that's why they're putting up bills to legalise marijuana for everyone to be able to buy it, as they do in some of the American states like Colorado. They have marijuana shops now where you can go and buy it. And Stuart will tell you the result of that use and the harmful impact it's had on the consumers. So would you give Dr. Reece a very warm welcome? Thank you.
Thank you so much, Fred and Anchor, for having me in your forum, and it's very kind of you. I'd just like to make a few acknowledgements before we get going. Firstly, to Professor Gary Hulse, who's been a very brave and courageous supporter for me for most of the 20 years that I've been in addiction medicine. Professor Maura Sim, the head of school at Edith Cowan University, has been very kind. Dr. Mervyn Thomas crunched a lot of the numbers we'll be working through today. from bioinformatics in Brisbane. He's one of the leading statisticians in the country. And Mr. Samuel Maxwell, who's one of my PAs in Brisbane, who actually downloaded a lot of this data painstakingly, the very old-fashioned way, off the internet. And just on the subject of... So this is the subject for debate. We're going to talk about today the dark side of the moon, the tormented souls on the dark side of the moon, the side of cannabis that no one ever talks about. And the first thing to know about cannabis is if you read the botanical literature, cannabis, see, plants can't get up and walk away if you're eating them, if a cow comes with them. So they've got to have poisons to defend themselves from other plants and other cannabis plants. And one of the poisons they use is the cannabinoids. And so you can see here where they've, where they put the cannabis on the leaf dies. So what we're talking about is a botanical poison. See the dead leaves here? A botanical poison that plants use to kill predators. Now, what we're not going to talk about today is what the research literature on cannabis agrees about. These are three leading world authorities on the subject of cannabis. Dr. Nora Volkoff, Director of National Institute of Drug Abuse, Wayne Hall, one of the leading professors in Australia for many years, and Health Canada. They all agree cannabis is addictive, it interferes with brain development, it's a gateway to other drug use, psychiatric disease, depression, anxiety, psychosis, bipolar, schizophrenia. It impairs the developmental trajectory. They don't get jobs and settle down and get married. It messes up your driving. It messes with the lungs badly. It causes immunosuppression, linked with stroke and heart attack. There are outstanding questions on cancer, we'll come to that, and gestational exposures, although all authorities express concerns. Increased potency in recent years and increased emergency room presentations. The potency was 1% in the 60s. It's up to 30% commonly now in Colorado. So it's dramatically increased in potency. So cannabis toxicity effects are agreed in the brain, acute intoxication, mental illness, gateway to other addictions, aborts normal life trajectory, so you don't get married and get a job, respiratory, the lungs, the bladder and kidneys, it causes bladder cancer, congenital abnormalities, bladder cancer, reproductive tract, male and female, causes cirrhosis in the liver, interferes with blood flow patterns in the liver and fibrogenesis and inflammation in the liver. Cancer, there's 12 cancers now, 3 cancers in kids, they're inheritable cancers, damage to the arterial system, heart attack, stroke. But we're not talking about any of that today because that's in the literature. And this is a very recent illustration of the gateway effect of cannabis. This is people who don't smoke cannabis, people who do use cannabis. It's 2017 data from Bertha Madras at Harvard University and Bob DuPont, who was the first inaugural director of NIDA, and showing that the drug use in all drug classes is much less with the cannabis. Now this is the patient information for Sativex. Sativex is a combination of THC and cannabidiol, and these are the warnings. It's not registered in the US, but these are the warnings on the patient information. All these warnings about pregnancy and breastfeeding, which are referring to genotoxicity. Now, as you know, last week the FDA in the US approved Epidemiology for childhood epilepsy. That's cannabidiol oil, just for children. You know, the little kids with refractory fits, and it approved it. But in there, if you read it in detail, you find there's warnings about its genotoxicity, damage to genes, and therefore cancer and heritable damage. Now we're going to start by talking about the mitochondria. These are the powerhouses of the cell, and they have a lot of functions. Oh dear. This is tricky. They maintain energy. There are a lot of things in the cell, but the key thing is to make energy for the cell. Now the point is, when the mitochondria get old, you get old, but if the mitochondria are young, your general health is young. And anything that changes the mitochondria from old to young is going to help you benefit, going to benefit your health. So there's tremendous interest internationally in nicotinamide riboside and terostilbene. There are 8 Nobel Prize guys doing this. If there's anyone in the room who's old or inflammatory or has diabetes or they're overweight or arthritis, this stuff boosts vitamin B3 and it boosts the energy in your cell. And so there's all these different brands of stuff. Tremendous, 8 Nobel Prize people. Harvard, Oxford, Cambridge Medical School. Tremendous interest in increasing the energy in cells to reverse the aging process, anti-inflammatory, anti-cancer. And these drugs also reduce the energy. All the addictive drugs reduce the energy in the cells. Now what you understand is, if the energy in the cells is high, then you'll be healthy. So your brain becomes strong, your heart becomes strong, your skin, your muscles, your gut, your hair, your ears, everything gets strong. But if the energy in the cells is low, then your health is trashed. When the energy is high, inflammation comes down. They're reciprocally regulated, right? So these vitamins increase the energy in your cells, good for diabetes, good for weight, right? Anything that brings the energy in the cells down is destructive for health. All the addictive drugs, including cannabis, interfere with cellular energy generation. Including these drugs, which are commonly they're called PPIs. This was written about in the British Medical Journal last year. These work by reducing stomach acid, and they reduce stomach acid by interfering with mitochondrial function, and they've been associated with increased death rate. So this is the tricarbolic acid cycle. As you can see, NAD is required. This is how the energy is generated in the cells. And NAD is required here. NADH is coming out, NAD goes in. This is the energy generation pathway in the cell, glycolysis and the citric acid cycle. The inner mitochondrial membrane spins, protons are pumped. This is the energy pathway. This is 1/10,000th probably of the chemical reactions in the cell, but the point is that the energy pathway is central to the whole. It's like the trunk of the Christmas tree. This is the central generator. This is a turbine that spins. As it spins, it generates ADP to make cellular energy. But cellular energy is required to maintain your DNA. So when the mitochondria fall over, when the energy comes down, DNA is destroyed and cancer becomes a big issue. So in most of the addictions have cancer as part of them. So tobacco, alcohol, cannabis, opiates as part of it. So these are the loops of the chromatin inside the nucleus that form that are regulated by the energy, and you see this all carefully regulated. They have these transcription factories that make the genes, and this is cannabis and mitochondria. You can see how it impairs the mitochondrial function, and these mitochondria blow up, as you can see, quite extremely as the cannabis concentration rises. And this is the effect of cannabis to impair mitochondrial function. This is in the airways. This is Don Kashkin's lab, UCLA. Dramatically impair mitochondrial function. Now the CB1Rs, this is cannabinoid receptor type 1, not only on the cell membrane but also in the mitochondria. This is that EM stain, gold, and just showing on the mitochondria. So the mitochondria themselves not only have the receptors, but they have the complex transduction machinery to regulate for both type 1 and type 2 cannabinoid receptors. All this machinery exists inside cells, and this shows anandamide and cannabidiol both interfere. Cannabidiol, which we're told is harmless, both interfere with energy generation. Actually, that's important. Why did I do that? See that one there? This shows that the NAD level, the energy level inside the cell halves every 20 years. This is one of the main reasons a lot of people think why you get old. So boosting it, this is more activation of the brain to think. So when this is an MRI scan of cannabis-exposed people, it controls and it takes more brain to do the thinking. Cannabis changes the cortex of the brain. This is the mortality in cannabis users. It goes up dramatically. You've probably heard the urban myth, cannabis never killed anybody. What a crop. This is the mortality in a 30-year study in Sweden, and you can see it's cannabis is the squares, and it goes up dramatically. There's the elevated mortality. And 30 times, and here's the relative rate, and it's actually 10 times higher in males, death rate, and 4 times higher in females. So here's mortality in cannabis users. To jumpstart you, if you actually investigate the question, does cannabis increase death rate? There's some references. These slides will be available through Fred on the net lately. Epigenetics governs health, memory, addiction, aging, diseases, cancer, and epimutations. Again, we have the DNA is coiled in around nucleosomes in the cell, and it has tails coming, that's a longitudinal shot histone tails, which are all regulated like traffic lights to control which genes are controlled or not. And these are shots of cannabis affecting the dopamine receptor expression in the midbrain. These are epigenetic changes, heritable epigenetic changes in dopamine gene expression changes, and all these things change with cannabis, except a dramatically altered immune function. The immune system sculpts the brain and does brain formation. Now this is interesting, this slide. It lists 7 cannabinoid receptors: CBR1, CBR2, abnormal cannabidiol, GPR55, PPAR receptors, TRPV1 or VR1, vanilloid receptors, and there's an O1819 one, and there's another CB receptor. So there's 7 or 8 different receptors that cannabis can affect the body. Now what I want you to understand is that as the concentration of cannabis rises, suddenly there's a devastating effect on cell growth. This is called a non-linear effect, and this is cell viability. You get to a point and bang, it cuts in. So you get to a point, bang, it takes mutagenesis, morphine self-administration, bang, it suddenly shoots up. Tubulin. Tubulin is very important, actin, mRNA. See, there's this drop, you hit a point, bang. This is called a non-linear. Now that means that the culture can be seduced. Because all the hippies that you were talking about say, we used cannabis when we were young, it didn't affect us, therefore we can flood the country with cannabis. Dead wrong. Because one of the dominant themes in the genotox literature for cannabis shows that you reach a threshold point and bang, the wheels fall off. This is very dangerous. And this is cannabis micronucleus. Now the micronucleus is, cannabis has been known since the 60s to cause tiny little nuclei due to single chromosomes that get isolated. And that's been shown to be a neutron bomb. And here you see damage to the nuclei in red cells, and this is thalidomide. So this is cannabis, has this sharp uptick, we call a non-linear dose response, just as thalidomide does in a similar assay. Now cells divide, as you know, it has a mitotic spindle here, the chromosomes separate, and the microtubules actually pull them. They have a plus end and a minus end, and they actually pull them apart. And when this is interfered with, you can get pulverization of the chromosomes, which can be very dramatic. And cannabis micronucleus formation is linked with this. It causes it, we know that now. And cannabis has been known to cause microtubular damage. This has been for some years. So this is a genetic train wreck you're looking at. Cannabinoids and cancer. Now these are 8 cancers, and these are 4 congenital cancers, inheritable cancers from cannabis. I don't have time to go into this in detail, but suffice it to say, this 150-page report from the Environmental Protection Agency in Canada, in California, agreed that cannabis causes cancer in those many different types. And if it's a carcinogen, it's necessarily a teratogen. Most carcinogens are also teratogens. So these are adult cancers, and most of the studies are positive, and childhood cancers are mostly positive. So, and all 4 of the testicular papers looking at testicular cancer are positive. Let's talk quickly about sperm little outboard motors here, but they're wrapped. What drives this outboard motor, they're wrapped in mitochondria that we talked about before. And this shows that cannabis interferes with mitochondrial function. Cannabis is involved in basically everything to do with male and female reproduction. That's normal sperm. These are the abnormal, bent, deformed sperm cells in cannabis-exposed mice, and there's a pus cell. So these are ring chromosomes from cannabis. This is the important Gabriel Nahas genotoxicity study done years ago. These are controls. This is a positive control. This is a cancer drug. There's THC. This is chromosomal translocations, major genetic damage. THC, cannabinol, and cannabidiol. They're all equally genotoxic. Now, this is not part of the public debate, but it is part of the FDA-registered patient information. Let's talk about brain formation quickly. Now, the brain forms, cells generate centrally, and then they flow through the brain. They generate here in the lateral ventricle, and they're in the subdentate gyrus, and then they flow throughout the brain to provide the brain with all the cells that it needs. And these are the adult rostral migratory stream, and he's streaming through there. This is up towards the nose, and this is into the cortex. They go into the cortex, and this is where you get your... And this is the hippocampus where memories form, and then there's a neurogenic niche there. This is the beautiful hippocampus, this is what it looks like. It's beautiful. This is where memories form. It's just so beautiful. And this is the dentate gyrus. This is the subdentate zone where these baby brain cells grow and populate. This is a close-up of the dentate gyrus, and the cells grow here. And as they grow, see the radial glia cells? There's 200 million of these complexes. They form the train rails, and the neural cells grow, and they run along that like train tracks to take that and form the developing brain. And then the brain matures due to immune activity to the age of about 20. This is a false colour picture. It's the impact of cannabis on birth defects. This is a great book. And if you read this book, Prenatal Cannabis Exposure, it talks about the thing. Prenatal cannabis exposure is lower birth weight, shorter birth length, lifelong smaller head circumference due to shrunken brains, reduced length gestation, neonatal neurological disturbances, reduced function in grade school, all the way through. These are 3 longitudinal studies now. Into early adulthood, they've got scans. How many toxins stop brain growth? All the basic functions of brain formation are affected by cannabinoids. And cannabis is linked with anencephaly. How many toxins do you know that affect brain function can result in no brain? And this is the CDC. These are references from the CDC in Atlanta, Georgia, saying that the relative rate of anencephaly in these 2 studies is about 2. And this is Nora Volkoff, director of NIDA, showing that cannabis interferes with stimulatory and inhibitory transmission. This is the cannabinoid distribution of the adult brain. the adult, the hippocampus and the amygdala, just showing the distribution. The changes to brain areas, the cerebellum, the prefrontal cortex with cannabis exposure. White matter connectivity. So this was an Australian study just showing that cannabis interferes with the connections in the brain and breaks it down by nearly 90% actually. These are high concentration CB1Rs on the developing rat brain autoradiography studies, show the high concentration here and how easy it would be to interfere with brain development. And this is a young six-month-old baby, died at 6 years. You can see the intense staining for CB1Rs. Then it's on axonal guidance, the CB1Rs guide the axons to form their connections, and when you mess it up, they get lost. This is altered excitation following cannabis, thinner neurites, thinner dendrites, reduced nerve cells form reduced neurite length, CB1Rs in neural and cortex development. These have intense CB1R staining, and these have grown. This is the pyramidal cell in the cortex. ECBs in cortex development. They're affecting all aspects of cortex development. Now, this is interesting. This is human cord blood induced pluripotent potential stem cells. So this is, you take the fetal stem cells from the blood and you turn them into neural stem cells, and as you do, you watch the CB1R expression come on in a big way. So it alters and the cannabis alters the NSC, the neural stem cell synaptic activity. Let's talk about the heart. Now the heart doesn't look like that. It looks like that. And it's got vessels on the outside, and it's got a complex structure with the four ventricle chambers. And you see there's a certain twist to it, which is normal. A normal heart has that. It's got these complex systems. So how does it actually form? Well, it forms as two arteries which come together, and then it bends, and then it starts to coil. This is all very complicated. Whoops. You see here, and this area, which become the interventricular septum, the membranous area, and the cardiac valves, the atrioventricular valves, is called the cardiac cushions, which have a high expression of CB1Rs. So you can see this is the kind of ventricular ridge that separates the two outflow tracts, high expression of CB1Rs there. And it's this area which cannabis can interfere with, causing defects in the grown animal, causing all these type of ventricular septal defect types. So cannabis effects. This is the American Heart Association, the American Academy of Pediatrics, showing that the rate of these serious ventricular septal defects and Epstein's anomaly, which is a pulmonary tricuspid valve problem, are about doubled. And this is the joint statement to say that this makes cannabis a known teratogen. Because of this, we know that cannabis damages heart development. And this is what these people want to legalise. That doesn't make sense to me. And these are adverse effects of CB1Rs on arterial pathophysiology is mentioned by these references. It's not exhaustive, just to get you starting interested. And the endocannabinoids are expressed in arteries as a key feature of arterial function, and it's involved in all these pathologies. Now, I bet you're glad that ECG is not yours. Nearly 6 seconds of cardiac arrest after acute exposure to cannabis. No cardiac activity. Sinus arrest there. And this is acute heart attack. And all these patients are reported in literature to be exposed to cannabis and had arrest, most died. And this is what's going to be rolled out. Now, how long does this take? Well, it takes 1 minute before the damage of the arterial system is significant. And we looked at our patients. This is an arterial looking at vascular stiffness, and we found that the cannabis exposed were much stiffer than the non-cannabis exposed patients. It's about a 25% effect rate. Talk about kids. Now, the best system to model embryogenesis or teratogenicity is rabbits, because they model it with best. But at high concentrations of cannabis, which is modelled in rabbits, they got a lot of cancers, marked inhibition of cell deficiency, phocomelia, no limbs, omphalocele, where your guts are hanging out, spina bifida, exencephaly, there's no head, no brain, myelocele, your spinal cord's hanging out. This is a formidable list, and this is described the antimitotic action and the embryotoxic action of the cannabis. So that's in rabbits. Experimental work from the 60s, very controversial. Now this is in people in Hawaii. Now these list of 21 defects, look at the rate here, 40 times normal for encephalocele. This is a major hypoplastic left heart, 30 times normal. This is the confidence intervals. Hydrocephaly, cleft lip, atrial septal defect is common. Gastroschisis here, 23 times normal. So atrial septal defect, there's a defect there in the atria. tetralogy of fellows, so the babies go blue, especially if they do anything or if they feed. So there's the blue baby syndrome. Paternal cannabis is the largest contributor for one congenital heart disease. The biggest risk factor these authors wrote was not the mother's exposure to cannabis, it was dad's. Dad's exposure to cannabis. So no one's talked to him. This is anencephaly. This is anencephaly. Gastroschisis. Dead bowel, dead liver, dead bowel, dead baby. This is Queensland's gastroschisis. This is New South Wales gastroschisis. New South Wales chromosomal abnormalities. This is when they published data. They haven't published data for 10 years. Birth defects exceed the New South Wales average. Now this is fascinating. You read this article, there's the link, these slides will be available on the net, and it gives the name, it gives the birth, and the mother says, I didn't use anything in pregnancy. My patients swear to me that is a cannabis pouch around dad's neck, and that is the baby who was born with cannabis. So all these mothers are blaming themselves for these fetal anomalies, and it's not even their thing. Western Australia, there's the chromosomal defects. Gastroschisis is rising in WA, but omphalocele not rising so much. In Australia, we haven't published nationally. There's no data for Australia, Fred, since 2002. But you can see there's a steep rise there, and omphalocele. Gastroschisis, this is really interesting. What happens is the gastroschisis is rising more in the developed nations, except for Mexico and South America. Now, Mexico is a major cannabis producer. And South America's got Uruguay, who've got legal drugs. So to me, this is the nail in the coffin of legal drug policy. When you look at the cannabis use is much higher in the developed nations, developing nations, and so is the gastroschisis. So that seems to make a link. Gastroschisis in the UK. So there's the gastroschisis rate in the UK. Congenital anomalies, Canada, fascinating. This is all congenital anomalies. Look, Nunavut, Newfoundland, up here, that's where they all are. Nunavut, Newfoundland, cardiac anomalies. Orofacial cleft lip, cleft palate, it's all in the north, and it's the north part of Saskatchewan and Manitoba. And up here in Nunavut for gastroschisis. And look, the gastroschisis rate across Canada varies tenfold from Nunavut to Quebec. There's a tenfold variation from 27 to 123. And it's not only between the states, but at the sub-state area. Look how small. There are pockets of gastroschisis. Why? We don't know. This profound paper is the best paper in the world. Now look here, cannabis exposed to gastroschisis. There were 8. See, it says 8? 8 times higher there. This is the best paper in the world. And then marijuana, cocaine, most of these, when you adjust it for everything, 4 times higher for marijuana. Most of these illicit drugs are marijuana. So they wrote in this review soon after that marijuana is associated with a 3-fold risk of gastroschisis. This is a world author in these. So the question is, where do they smoke the cannabis in Canada? In Canada? And sure, Manitoba, Saskatchewan, Newfoundland. And there's no data there for none of it. So that's the age of first use. This is the rate, Manitoba, Newfoundland, right? Prince Edward Island. So these northern reaches getting the highest reading. And when it comes to Nunavut, you can mail, this is before legalization, cannabis, you can mail order, and 85% of men and 70% of women in Nunavut smoke cannabis. And that's why they come top of the pops on all congenital defects for which the Canadians have data. So cannabis co-occurs with congenital anomalies. And in fact, cannabis is linked with all these. If you look at why infants die in the first year of life, it's linked with all these major causes. So gastroschisis is rising in America. This is the younger mothers. It's a teenage mother problem. No one knows, they say, why it's so much more common in younger women. And then it continues to rise. They look at it a few years later and it's still rising. And cannabis use amongst pregnant mums in California, that's who said they were positive. That's positive toxicology, and that's the test. They tested. So 8% of all the women in California were positive. But if you look at the teenagers, 25% of all the girls, the teenage mums in California, having babies, are testing positive for cannabis. 25%! And it's a known teratogen. But thalidomide only affected the mother, and it wasn't everyone affected it. This is affecting the dads even more powerfully than the mum. So I want to know why we're rolling this stuff out. 25% of the Californian ladies, and you'll be pleased to know that I've got colleagues in Colorado who are interested in looking at the defect rate that go with that. Now, so here's the cannabis use. See, it's more in the teenagers, and the gastroschisis is more in the teenagers. And the question is, are these two linked? So cannabis use, California gastroschisis rates by age. And you can see there's a close link. Now, this is gastroschisis rates in the USA. This is from this paper at the CDC. And the point is that it's much higher in the young, but it's doubling even in the young ones, obviously, as cannabis takes hold. In all strata, it's going up. This is Washington State, the rising gastroschisis, but it's rising faster in the teenagers who are using more cannabis. North Carolina achieved a doubling of their gastroschisis rate from 2 to 4.5 in 3 years. And they're the 3 years that cannabis took hold in North Carolina. So it came from Mexico to North Carolina. North Carolina's doubled. Gastroschisis rate doubled. In Mexico, we saw the gastroschisis rate went up 25 times, and it came from Mexico. So not only did it go up rapidly in North Carolina, but along the supply line from Mexico, the gastroschisis rate went up as well. So gastroschisis rate in the last month, and this is 4 American states. You've got Arkansas, Georgia, Texas, and Utah. Utah's conservative, and see, the more the cannabis use rate rises, the more the gastroschisis rate rises. And this is the US cannabis use by state, and overall the gastroschisis rate is rising there on this data. When we regressed the cannabis gastroschisis rate, state, year, and cannabis use, we found that, see, this is the last month cannabis use. All these ones, it's highly significant in all these states. And some of these states like Oregon, Rhode Island, Alaska, California, it's legal. So this is that one's not corrected for abortion rate, and this one is corrected for abortion rate. Comparator is Alaska global. So this is a global univariate meta-analysis of cannabis gastroschisis. So there's 6 papers published that we know about in the literature looking at cannabis and gastroschisis rate. Overall, there's a 4-fold elevation in the risk. Now, New South Wales, I don't know if you know, but in 2011 there was an outbreak of gastroschisis in the Northern Rivers area, and they wanted to know whether this was disproportionate. And there were some serious mistakes. The numerator was wrong. There were 5 cases talked about, not 8, as the press found. The denominator, you can make the rate go down by just making the area bigger, which I think the report did. And then the statistical correction was incorrect. They divided their P's by 9 instead of 150, which is wrong. So Queensland versus... Now, in Queensland, most of the anomaly rates are flat, except these ones which have been grouped with downs. So these ones are all rising. The green is interstate, outside Queensland, which mostly come from northern New South Wales. You see all these cannabis, which ones have been attributed, are much higher, except alcohol. It's not alcohol. And then these are the commonest ones, which are all linked with cannabis. So this data proves it. Now, I wrote to New South Wales Health and said how many gastroschisis cases you had. You know what the answer was? We've had 1 case in the last 5 years in New South Wales, in the Northern Rivers area. And it turns out there's a neonatal retrieval system. You have a sick baby, the choppers come in, they pick it up, they take it to Brisbane. So Brisbane pays the bills, Brisbane looks after it, Brisbane makes all these babies better, and they don't shop on the Sydney books. So I asked Brisbane, well, what's the denominator? And the answer was, we don't know. So there's a silent epidemic. So the Northern Rivers area of New South Wales is not only producing all the defective babies and shipping them across state and having someone else pay the bill, they're also producing all the cannabis for the country and shifting their poison across the bill. So if you look at the rates in Queensland compared to these other ones, in each case, these cannabis-related data, it's much higher, except for fetal alcohol. So it's not alcohol is not the problem, it's not driving it, but it could be cannabis. And then this is the relative rise in northern New South Wales compared to Queensland. And here's gastroschisis, and it's 5 times 5. Now let's look at Colorado briefly. These are major congenital anomaly numbers in Colorado. So you see a 70% increase in 2000 to 2013. The legalization in Colorado happened progressively from about 2004, but it's a 70% increase. Now this is scary. This is the rate per 10,000. It's 12%. 12% of the babies, 1 in 8 of the babies in Colorado has a major congenital anomaly, according to Colorado Health. The going rate is 3%, and Colorado is 4 times that. At the beginning of this time series, it was 7%, but it's 12%, and they're exporting this globally. These are the actual numbers on the slides. These are cardiovascular anomalies, ventricular septal defect, atrial septal defect. Carefully, if Zika virus had doubled in this period, there'd be a public outcry. Chromosomal anomalies. Close correlation between cannabis consumption, congenital anomalies rates, the correlation coefficient is 0.95 and the p-value is less than 1 in 10,000. So these figures, at a conservative way of doing this calculation, suggest there's been an extra 20,000 deformed babies born in Colorado in just a 14-year period, 2000 to 2013, which is significant. Now you think, well, what drugs in Colorado? Because we know about cannabis, but maybe it's cocaine. Wrong, cocaine's dropping, opiates are dropping, tobacco's dropping. But look at the correlation with cannabis and the p-value. And when you do the regression, it's all cannabis. The other ones drop out. So less than it's about 2 in 1,000 chance is as tight. So this is Colorado drug deaths. You've heard that cannabis reduces opiates. Wrong. all the drug deaths are rising in Colorado, including the cocaine, and on the back of this drug epidemic. This is the drug poisonings up, so that's prescription opioids, and that's the methamphetamine. They're all up on this back of this drug culture. So let's take a quick look at the USA. These are the states we're interested in. These are the leading states from the CDC which have decent birth defect numbers. This is the cannabis use data. That's 2002 graph, and this is the US government stuff, and that's the most recent graph. So the cannabis use is higher in the West than the East, but they make the rules in the East. So we've looked at it too based on the data that we've collected. Alaska, Colorado, Oregon and DC are high. Atrial septal defects, high in Kentucky. See the light states are the higher, and Oregon. Atrial septal defect, Oregon, there in Alaska where they smoke a lot of weed. Patent ductus is not associated. Arkansas is high in gastroschisis, high in California. And Down syndrome, Colorado, Oregon, I think that's Massachusetts, and Alaska. So we looked at cannabis use rate by state, cannabis consumption quintiles, so we can divide those into quintiles, and this is the way it's risen in quintiles. You see they're very different. See the notches here don't overlap, so they're significantly different. The cannabis use by legal status, as it becomes more legal, it gets more used. So if you want cannabis to flood your country, go ahead and legalise. This is the legal status, this is illegal, decriminalised and medical. So the way to keep cannabis use rate low, if you want to protect your babies, is to keep it illegal. And there was a regression there to show that that legalisation, C is highly significant, P less than 0.05 is highly significant. So cannabis use rates and by de facto legal status, you can see it's much higher by legalisation. Now, cannabis-related anomalies over time, this is corrected for the abortion rate. You can see these are cannabis-related, this is over time, most of them are rising. And this is the cannabis index. Cannabis index is the cannabis use rate times the cannabis concentration. In most cases, all these 26 defects are rising. This is abortion-corrected. Cardiovascular anomalies are rising by concentration. This is the regression, cardiovascular defects, less than 0.05 significant. This is the raw P. This is the corrected for multiple testing. All these ones are highly significant. Corrected. This is endocardial cushions. We talked about the derivatives of that. This is the cannabis index. And this is the regression, endocardial cushion derivatives. This is the Benjamin Hochberg. The atrial septal defect is significant. Common truncus Epstein, tetralogy of Fallot, double outlet right ventricle. This is the uncorrected. This is just the anomaly rate live born. This is corrected for an estimated abortion rate for literature. We don't have the actual abortion data for the US, but I'm interested in getting it. Chromosomal anomalies by time. This is the chromosomal anomalies by time and this is by time. See the rising rate in chromosomal anomalies but over time, and then expressed as a cannabis index, the use concentration index. It's rising. If we put in if we correct for these are estimated abortion rates, it's rising much faster, both over time and by cannabis use concentration. Chromosomes. So this is analysing the effect of the chromosomes. This is the abortion, this is the reported rate, and this is the log of the abortion corrected rate. You see it's highly significantly raised. This is the gastroschisis rate is significantly associated with cannabis use in this data. Defect rate by highest and lowest quintiles, you compare the two quintiles. In most of these cases, the higher rate of quintile 5 has got a higher rate of anomalies. So if you look at this is a heat map showing that as cannabis use rate rises, which is here, see cannabis use rising, then the major cardiovascular defects rises with time, major CNS defects rise with time, major musculoskeletal defects rise with time. So as the cannabis rate rises, so a lot of these other defects. Let's talk about kids. Now, the commonest question I have is which defects are actually linked to cannabis? So let's ask that. That's a good question, because as you can see, we've talked about a lot of defects here. Some are implicated, some aren't. And the evidence for some is strong, the evidence for ones are weak. So these are the ones I think where it's weak, where it's strongest. Anencephaly, the CDC told us in those two reports, and they also implicated gastroschisis. That's implicated by the CDC reports, the meta-analysis I just showed you, the Canadian data, the New South Wales, Queensland data, and also severity is implicated by the published literature. Diaphragmatic hernia, the CDC, esophageal stenosis with or without tracheoesophageal fistula, ventricular septal defect, Epstein's, cardiovascular disorders, Colorado, the AHA report, the Wilson report on the attributable rate I showed you, and the present study, ASD, atrial septal defect, Colorado, and chromosomal defects due to these. Then the brain defects, which we talked about at the beginning, intelligence, high cortical function. First the reasons for that: first principles, it affects stem cell niche behaviour, because the stem cells don't exist by themselves. They've got a niche that the nervous system looks after them. The neural stem cell wiring, axonal guidance, epigenetics, immunity and brain inflammation, vasculopathy, it damages the large and small vessels. The small vessels are part of the neurogenic stem cell niche. Longitudinal studies, the three major longitudinal studies of this question are all, and anencephaly. Anencephaly is presumably the extreme example of it grossly interfered brain development. The question is how? Well, epigenetically, it affects microtubules, as I showed at the beginning. It affects the mitochondrial functions we showed. Secondary, it affects the low cellular energy charge, which then affects the DNA maintenance. Damage to reproductive tract. Fetal vasculopathy. The blood vessels of the fetus get interfered with. Cannabis can cause inflammation through the CD1Rs, the GPR55s, and the vanilloid type 1 receptor. Damage to the stem cell niche. There's an aging effect, mitochondrial toxicity, carcinogenicity, non-linear kinetics. Damage to the brain formation neural network to the point of anencephaly, so it damages brain formation to the point of no brain. Damage to the heart formation endocardial cushions through CBR1 and GPR55, and there's a threshold effect we talked about. Let's talk quickly about clinical trials. Now, when you go to the clinical trial website, there are 2,020 sites if you search those four terms. So there's a lot of intense interest. I looked at this 18 months ago, which is probably a bit out of date now, but the results were disappointing. There were that many patients in the trials. There was pain mostly in MS. The primary P was often significant, but there were many major failures on the secondary endpoints, and the severe side effect profile, most of them had, 80%, 90%, 93% with side effects. Now, as I said, Epidemiology has just been approved. That's in children with pediatric epilepsy, so they're not going to have babies. And if you read the FDA literature, patient thing that I showed you, genotoxicity is a major warning. So medicinal chemistry, this is very exciting. Receptor structure, medicinal chemistry subject. If you Google the structure of the CBR1 cannabinoid receptor, there's 900 papers on the PubMed search. There's a lot of interest. This is what the cannabinoid type 1 receptor looks like. And you can see it sitting in the membrane here, and these are the drugs in the pocket. And right here, now this means medicinal chemists are so clever, they've got programs that can design a drug to fit in this. So once we understand better how this system works, because it's got so many effects, we think we'll be able to produce amazing drugs. So it's a very exciting thing. But in terms of legalising cannabis, we're not at that point yet. But the future could be very exciting. Now, you mentioned that some people are very keen on advocating cannabis. This is one of the brightest people in the pro-cannabis camp. The Last Sorcerer, Echoes of the Rainforest. Can you wait, Freda? He's written a book. This is about witchcraft in the Amazon, casting out the Christian missionaries. So the king has got no clothes on. The cannabis king, I think, has got no clothes on. This is Colorado. This is pediatric poisonings. Look at that. There it is in the US, and there it is in Colorado, jumping off the Richter scale. Calls to the Colorado Poison Center was dropping. They had legalization, took off like a rocket. This is the birth numbers in Colorado. People are fleeing Colorado. This is a 6'2" detective beside one 12-foot cannabis bush. This is the slums, the cannabis slums of Colorado, which probably are not mentioned by the advocates. This is Nimbin. Guess what the idol in Nimbin is? Guess what the pagan parade is, the neo-pagan parade? This is the cannabis church in Colorado. Colorado has at least half a dozen cannabis churches. It's all very new age. There's an old Lutheran church, they bought it out. And over again, when we talk to premiers and people like that, we get a Sergeant Schultz. You can see how much literature, we've just touched the top of the volcano of literature. Over and over again, you get this brain-dead answer from the powers that be, prime ministers. You've got Prime Minister Trudeau in Canada is just on the 1st of July legalised, and now President Trump wants to follow suit. They're aware of none of this. I think they should be making it known. Of course, Canada is known for its Mounties, but one wonders what they want to turn the Canadians into. Now, this is Nora Volkoff, the director of NIDA. She's saying this is past year cannabis use, and this is perceived risk. I don't understand why these data, this sort of information we've talked about in this talk, is not being made widely available in the press to everyone, the whole community. I'm very grateful for Fred for this opportunity to talk about it. This is Nora Volker's graphs, and this is the cannabis concentration review of the rising cannabis up to 2012. Of course, it's much stronger now across the US. So this is the evidence we've mentioned. Cannabis toxicity affects all those things. Cannabis affects babies, car drivers. See, if cannabis is bad for babies, car drivers, commercial drivers, pilots of airplanes, workers with manual tools, construction, and construction jobs it should be, children, adolescents, females of reproductive age, males of reproductive age, pregnancy, lactation, workers, older people with mental illness, immunosuppressed, asthmatics, people with personal history of cancer, people with family history of cancer, people with personal history of mental illness, people with family history of illness, and of course accelerated in the whole population. Who's it good for?
Nobody.
So why are we legalising? So in other words, cannabis legalisation has far-reaching public policy and public health implications for many generations. We mentioned epigenetic change. That stuff's inheritable for 3 and 4 generations. That's the next 100 years. You're selling down the river. Why? Legalisation. Now, and John Snow, in 1854, took the handle off the Broad Street pump and stopped the cholera epidemic in the East End of London. Why are we seeking to put it back on with legalisation? And this can be done today. This is Iceland, the highest to the lowest drug use in Europe in just 19 years. So this is my address today, Recasting the Cannabis Debate. You'll see why I've chosen that title. Efficacy, genotoxicity and teratogenicity. Thank you for listening and thank you for your attendance so much.
Wow.
Sorry, I'd just like to finish with one final quote from my friend who's a doctor in Colorado. He's a very senior doctor and he sits on the board in Colorado. He says, "Don't fly the plane before building it. Follow the science, not the money, as this could be the largest Trojan horse of all time. I invite you to visit Colorado and see firsthand the marijuana refugees. Spend a shift in an ER where marijuana-related illnesses are seen each and every single day. Talk to the first responders who need to shower and clean their clothes after every shift because they smell like marijuana. Meet the families that have been affected or lost loved ones related to marijuana."
Well, thank you, Stuart. You've given us a lot of food for thought.